Welcome back to COM 3693, Interpersonal Health Communication. Today, we're going to address individual differences in the reception of healthcare. Specifically, I'm going to answer the question, do certain people receive poorer healthcare because of their identities? In this lesson, we're going to talk about implicit and explicit biases that happen in medical care to people of different races, genders, social classes, and sexual orientation. This is Angela Anderson, a leadership and mental health professional, a best-selling author, and a certified coach and trainer. In 2021, Angela shared a compelling story on her Instagram of her harrowing experience getting medical care during the height of the COVID-19 pandemic. One night, as Angela was preparing for bed, she experienced a localized pain in the right side of her chest and back. She made it through the night, but the pain persisted, so she, in consultation with her husband, who was a medical doctor, decided to visit the nearest urgent care facility. When the provider came to her car to do the assessment, the doctor quickly looked in her nose, told her she was congested, gave her medicine for her postnasal drip, and tried to send her on her way. But at her insistence, the doctor agreed to do a chest x-ray. He told her flippantly that he would be happy to give her a couple doses of radiation, so long as she wasn't pregnant. When the doctor finally checked her oxygen levels, he unsolicitedly told her that the pulse oximeter sometimes doesn't work on colored fingers. When they finally got the results of the x-ray, she asked about the shadows on the film near her lungs, which is usually a sign of an infection. The doctor responded with, quote, "It's hard to see the lower part of the x-ray because you have breasts." With that, she was sent home. 2 days later, not feeling any better, Angela went to another urgent care facility, explaining how her care at the first one was mismanaged. She was immediately taken to the ER for a CT scan, a full blood panel, and an echocardiogram. She had not only a pulmonary embolism in the lower lobe of her right lung, but also pneumonia and an infarction that caused some of her lung tissue to die. Cases like Angela's are unfortunate, but they are not uncommon, especially for specific subsets of the population. Indeed, Angela and countless others experience poor access to healthcare because of some aspect of their identity. When we think about the term bias, we often think about it as a tendency to believe that some object, whether it's a person, idea, or thing, is better or worse than others and often leads to unfair or unequal treatment. When we think about a specific person, we have a natural tendency to associate specific attitudes with them, consciously or unconsciously, based on the social group to which we perceive them to belong. When we knowingly hold certain cognitive associations between people of a given social group and certain feelings, concepts, and evaluations, we call them explicit biases. When the set of associations about a specific group are held unconsciously, we refer to them as implicit biases. In the book Everyday Bias: Identifying and Navigating Unconscious Judgment, author Howard Ross described the process of implicit biases by writing, quote, "Categorizing people without realizing it is as natural as breathing and allows us to navigate the world." Indeed, implicit biases are everywhere. They are automatic and so ingrained in people that it becomes almost a reflexive response. For example, close your eyes for a second and imagine that you tore your ACL in a sports injury and that you're told that you're going to need surgery. Imagine for a second what the surgeon who's going to perform your surgery looks like. In your head, was it a male? If so, this could represent an implicit bias you hold about the medical profession. The same is true if you automatically and unconsciously think about a female if I refer to an elementary school teacher. Both implicit and explicit biases pervade all aspects of our lives. Some areas where we can view these biases are in police-civilian interactions and criminal sentencing in the criminal justice system, perceptions of athletes' skills and skill levels, story narratives in popular media and story selection in news reporting, recruitment and hiring practices in the workplace, perceptions of quantitative and written or spoken abilities in education, and even when sitting at the coffee shop and panning the room for potential conversation partners. When looking at another person, we sometimes have a reflexive, unconscious response to associate certain attributes, beliefs, or attitudes towards him, her, or them, which can ultimately affect how we treat that person. Given your knowledge about how implicit and explicit biases can infiltrate all aspects of our lives and create inequities for people of certain ages, races, genders, sexual orientations, ability levels, and socioeconomic classes, it is likely not surprising that these biases can also play a role in our healthcare. According to an article entitled "Tackling Implicit Bias in Healthcare," published in the prestigious New England Journal of Medicine, author Janice Sabin noted that even those who have egalitarian beliefs about rights and privileges can still harbor implicit attitudes and stereotypes that go against those conscious beliefs. She says, quote, "In medicine, bias-driven discriminatory practices and policies not only affect patient care and the medical training environment, but also limit the diversity of healthcare workforce, lead to inequitable distribution of research funding, and can hinder career advancement." You might be asking yourself at this point, what are the inequities in healthcare that are created by implicit and explicit biases in medicine? In a systematic review of existing literature published in 2017, authors Chloe Fitzgerald and Samia Hurst examined the entire body of research on implicit racial biases among healthcare professionals and extracted 42 articles that met their eligibility criteria. The review included perceptions of physicians, nurses, and other medical professionals, and their results were astounding. They found that healthcare providers' implicit racial biases is associated with greater diagnostic uncertainty, or the idea that providers were less confident in their ability to provide an accurate explanation of a patient's health problem, lower ratings of interactions, less patient-centeredness, poor communication, less likelihood of receiving pain medication for acute injuries, and the perception that Black patients are less adherent to medical intervention plans than white patients. What does this bias result in? According to the National Academy of Medicine, Black and Hispanic patients receive lower quality health care than their white patient counterparts. When they say low quality care, they mean that people of color are less likely to receive appropriate cardiac care, to receive kidney dialysis or transplants, and to receive the best treatments for stroke, cancer, or even communicable diseases. This is true when all other factors like age, socioeconomic class, gender, and sexual orientation are accounted for. From the years of 1950 to 2004, Zhu and his colleagues found that Black males had a 1.7-fold increase in mortality rates from cancerous tumors than white individuals. In 1952, the American Psychiatric Association, the Charter Association for Psychiatrists, published the influential first edition of the Diagnostic and Statistical Manual of Mental Disorders. The DSM-1 centered around three classes of symptoms: psychotic, neurotic, and behavioral conditions. Among the different mental diseases, homosexuality was listed as a sociopathic personality disturbance that was interpreted as a supposed pathological hidden fear of the opposite sex caused by traumatic parent-child relationships. In the text, they wrote that individuals with this disorder may have either no or very weak heterosexual arousal. Typically, there's a history of unsuccessful attempts at initiating or sustaining heterosexual relationships. In some cases, no attempt has been made to initiate a heterosexual relationship because of the expectation of lack of sexual responsiveness. It wasn't until 1974 that homosexuality was no longer listed as a category of disorder, but they persisted in including a category called sexual orientation disturbance. The effect of this characterization of the LGBTQ+ community in healthcare still reverberates today. How does bias play a role? Well, a doctor may ask a male patient, "Do you have a girlfriend?" while taking a sexual history rather than using the term partner. Or a nurse might ask a female patient, "Are you sexually active with men, women, or both?" And when she responds that she's active with one female, the nurse skips the question about condom use despite the female partner being a transgendered woman. Finally, a doctor might turn to an openly gay patient and say something like, "You really need to be vigilant of protection with your partners," making the assumption that the male patient is actively having impersonal sex with multiple partners. Gender and sex bias is also present through the healthcare system. Numerous biases persist about differences between male and female patients by their healthcare providers. A comprehensive review of literature conducted by Anke Samulovitz and her colleagues in 2018 narratively summarized the findings of 77 articles on the topic of sex and gender differences and the patient-provider encounter. When it came to complaints about chronic pain, providers would view men as brave and stoic, whereas women who complain about chronic pain were viewed as emotional and hysterical. Additionally, when it came to the management of this chronic pain, doctors were more likely to interpret women's chronic pain as a byproduct of an underlying mental health condition, but for men, they saw pain stemming from a legitimate physical condition. In June of 2023, Medicaid.gov published a report saying that over 92 million children and adults in the US participated in either Medicaid or the Children's Health Insurance programs. Unfortunately for these patients, insurance-based biases can lead to suboptimal healthcare, which occurs less frequently and is often delayed. Those on Medicaid regularly report a lack of confidence in the healthcare system, experience provider-level barriers such as apathy and indecisiveness when seeking care, and have lower satisfaction with the care they receive. So, with all this new information about the explicit and implicit racial, sex, sexual orientation, and class biases that might occur in the healthcare system, the natural question you might ask yourself is, how can healthcare providers overcome the biases they might hold? And this is a great question that has received only modest attention in the literature. Here are a few strategies. There are some strategies that might help to reduce the implicit and explicit prejudicial images that healthcare providers might hold. It's important to note that because implicit biases are unconscious activities, the first step providers must take is to bring the bias up into their consciousness. The first strategy is called stereotype replacement. In this strategy, healthcare providers practice replacing stereotypical responses to bias with non-stereotypical responses. For example, a healthcare provider can practice stereotype replacement by asking, "Do you currently have a sexual partner?" rather than asking about an opposite sex partner. This strategy involves acknowledging that you sometimes have responses to people based on your own preconceived notions, identifying when this happens, considering why this happens, and responding in non-stereotypical ways. The second strategy is called perspective taking, where the healthcare provider assumes a first-person perspective of a member of a stereotyped group. The third is called counter-stereotypic imaging, where the healthcare provider is challenged to make a position association with an image that's the exact opposite of their stereotype. For example, a doctor may stereotype a mentally ill person as more dangerous than the average person in the population. In this strategy, a doctor could think in detail about someone famous who doesn't act out violently, like Leonardo DiCaprio or Demi Lovato. One could even think of an abstract other like an ambiguous, nonviolent person with a mental illness. Finally, the last strategy involves increasing contact with the outgroup member by going into the community and having positive interactions with them. Some even argue that having imagined outgroup contact can serve a similar end goal. That's pretty much all I have for this module on implicit and explicit biases in healthcare. In this module, you learned about what implicit and explicit biases are and how they can creep into all parts of society, including medical care. You learned that individuals who hold specific traits can be marginalized within the healthcare system. Finally, you learned how healthcare providers can lessen the potential negative effects of the conscious and unconscious biases they hold. As usual, if you have any questions, please drop them in the comments of this video or feel free to email me. Thank you for watching to the end, and I'll see you again next week.